Right. Okay. So first things first, can I just say I mean, very grateful for the invitation. Eid Mubarak to everyone. And I think I commend Dr. Abdul Azim's intentions of trying to get knowledge spread in the world and time where we are all isolating and not able to meet. So this is a fantastic forum on which we can share our knowledge, experience, and our thoughts and learn from each other. So thank you for the invitation, and it's a pleasure to be here. And Dr. Adlan, thank you for the invitation as well. Can I just point out a slight correction? I am also an interventional cardiologist. I have an interest in heart failure, but the services in our institution are led by Sam McClure and Martin Farrer in terms of the development of heart failure and sort of services as such, but I have a contribution to that and an interest in particularly in acute heart failure in the context of coronary disease to start off with. So those are my sort of positions. I have no conflicts of interest to declare. These slides are my own as such, and I've tried to keep it less intense in the sense that I have not put on too much data stuff. First things first, I would like to say the plan would be to give you some background information, talk about cardiovascular injury, clinical presentation, define some treatment and some prognostic sort of indicators. And I'd be grateful if people would either wait till the end for questions, or if you feel that there is need for you to ask questions, by all means, feel free to stop me and ask questions as such. I just need to exit for a second to try and see if I can just correct this, because I am not able to see some of my slides. Give me 2 seconds, please. Right. Can I then share? Give me 2 seconds, please. Is that better? Yes, I can now see it better. Okay. So I'm just going to talk very briefly on the renin-angiotensin-aldosterone system. And just to recap on what we've got thus far, it's important as, you know, it looks like the mechanism by which the COVID seems to be affecting the various organs is primarily through its interaction with one of the components of this renin-angiotensin-aldosterone system. So towards the left of the slide, we can see where the angiotensinogen is coming from the liver. As it travels, the first ACE, angiotensin converting enzyme, secreted from the lungs converts that angiotensin 1 to angiotensin 2. So angiotensin 1 is obviously derived from angiotensinogen by the action of renin, which is coming from the kidneys. So you're getting the feel for this whole pathway being controlled by a number of organs and a number of processes. Once the angiotensin 2 is formed, it has a number of positive impacts on different places: sympathetic activity, tubular absorption of electrolytes and fluid, onto the adrenal cortex for further aldosterone secretion, on blood vessels, on the pituitary gland, so on and so forth. And towards the right of the slide, you can see the impact of these effects of angiotensin 2 on the various organs. At the end of the day, on the very right-hand side, when the water and salt retention takes place, there is effective circulating volume is increased, and the perfusion of the capillaries and the glomeruli in the kidneys is impacted. And then you see a negative feedback over to the renin to say, actually, let's just reduce the angiotensin 1 production because we have enough. And this is your normal mechanism that works through. The COVID seems to be hitting the organs where this mechanism impacts. The way it is doing that is by sharing its contact point with the angiotensin converting enzyme 2, which sits on the surface of the cells in various organs. When it does that, it is internalized into the cell. And once it gets into the cell, as Dr. Ahmed very elegantly described earlier on in his pictures, the virus seems to then disintegrate and start replicating and destroying the cell and moving on from cell to cell to cell. When COVID hit us and there was a suggestion that if people were using things like ACE inhibitors and angiotensin receptor blocker inhibitors, the number of ACE2 receptors on cells was increased because we were blocking the angiotensin 2, which would normally interact with the ACE2 receptor. So by blocking the angiotensin 2 or reducing the production of angiotensin 2, there were more receptors on the surface, and therefore the suggestion or speculation was that this would increase the likelihood of virus attaching to the cell and then being internalized. And therefore there was all this panic about stop ACE inhibitors and ARBs and so on and so forth. This was also compounded by the fact that the retrospective case series data from China in particular suggested that in those patients who had a poor outcome, there was a higher prevalence of hypertension. And those two factors were suggesting that if you were hypertensive and you were on ACE inhibitor, you were more likely to die because of this COVID infection. In fact, the meta-analysis of a lot of data coming through from not only from China, but also from America and from Italy is suggestive that the negative impact is actually not clinically relevant. And in some people, the treatment with angiotensin receptor blockers is actually protective. Now that has to be proven in randomized controlled studies, but there is a signal that we are seeing there. So the panic about stopping medications and ACE inhibitors and ARBs is over, and we should just be very clear that there is not a negative impact at all. So just recapping a little bit more in a text format for what Dr. Ahmed has already said. It's a beta coronavirus identified initially in early December 2019 in Wuhan in China. It's a large RNA virus, and it's similar to the SARS viruses of 2003. There is, roughly speaking, about 25 to 50% of people may be completely asymptomatic. However, they remain infectious and they remain infectious and able to transmit. And the viral shedding process in sort of observational data ranges from between 8 days and up to about 34 days. I've talked about the interaction with the ACE2 receptors, and the ACE2 receptors are present not only in the main organs, but also in the upper airway and oropharynx, which is where the internalization happens and the symptoms start from. And then the next couple of points I've already mentioned in terms of its interaction with angiotensin 2 and what it does with angiotensin 2. If you remember, angiotensin 2 causes vasoconstriction, increased aldosterone, and retention of salt and water, and so on and so forth. The ACE2 breaks down the angiotensin 2 into vasoprotective, i.e. vasodilator type actions. And therefore, if you don't have angiotensin 2, you have more of ACE2 floating around. And so on and so forth. And I've addressed the last point in my previous sort of slide. So the clinical presentations, again, we've already, Saeed has said this, and I'm saying this again. I think there's a shortage of randomized controlled trial data, which is not surprising. We are only about 4 or 5 months into the pandemic, and we're still collecting the information. A lot of it is now retrospective audit stuff and case series and so on and so forth. So just bear with us. I refer to 2 particular papers. One is the COVID-19 and cardiovascular system, which was published online in Cardiovascular Research about 4 weeks ago. And the other one is a registry data, which looked at nearly 17 million adult NHS patients, and published by Ben Goldacre. Ben Goldacre used to work in Sheffield, and he's now working down in London. And he's got a very, very good track record of looking at retrospective audit data and identifying cardiovascular risks and so on and so forth. He's very well published and respected. So he's looked at the 70 million NHS adult patient data and come out with about 7,000, roughly about 7,000 deaths attributed to COVID. This paper was published online a few days ago. So it talks about the virus being transmitted by aerosol, coughing, sneezing, and invasive aerosol generating procedures, incubation period ranging between 1 to 14 days, maybe up to 24 days, and a mean symptom emergence is around 6 days. The highest risk of cardiovascular impact happens about 15 to 20 days down the road, and possibly linked to the concept of cytokine surge that Saeed was talking about. And I'll explain that in a slightly different way, in that we understand that there are two mechanisms by which the virus attacks. One is by infiltration into the cells and destroying them, and that is termed as the cytokine or cytopathic impact. And the other one is essentially a delayed and a possible indirect impact, which is through neurohormonal modulation, and that is a delayed sort of impact. And therefore, you have two, possibly three different clinical presentations, one being the immediate sort of presentation of decompensated patients with perhaps heart failure, ARDS, AKI, and so on and so forth. And you wonder whether they've had the illness for a longer period of time, and then they present as a cytokine surge up front. Or you have people with the classical symptoms of cough, fever, myalgia, loss of taste, and so on and so forth, and they come in and then 6 or 7 days later, then deteriorate and have the typical cytokine surge while they're in hospital. The disease severity and outcomes are primarily dependent on host characteristics, so the immunity of the patient and any other demographic data that might impact, particularly pre-existing diseases and so on and so forth. And from all the data that we are looking at, whether they're published in mainland Europe, from UK, from US, or from China, the suggestions are that men who are over the age of 63 to 65 with a background of diabetes, from Black, Asian, minority ethnic background, elevated BMI, pre-existing cancer, particularly hematological cancers, having renal, respiratory, and cardiovascular disease, they tend to do much less well than individuals who are either younger or do not have these predisposing factors. I've deliberately left out hypertension from there because the data around hypertension is confounded by other factors in the studies, although hypertension in itself seems to be recognized as a risk for having a poorer outcome. Now, I know that Saeed did mention that there is a predisposition towards getting infection in certain groups. From the data that I've looked at, I cannot see any publication which tells us whether having cardiovascular disease, and it's a very broad term, people with coronary artery disease, people with arrhythmia, people with heart failure, and so on and so forth, or valvular heart disease for that matter, people who have had bypass before or stents before without left ventricular dysfunction, all the whole spectrum of this cardiovascular disease. I could not see where it says that these people or these patients are, or I could not see where one could identify a mechanism how these patients were actually acquiring the illness. But what is very clear is that if you've got that background and you get a COVID, no matter where that source is, whether you get it at work, whether you get it out in the shopping center or whatever, that the outcome in these patients is much, much, much worse than it is in patients who do not have these predisposing factors. The clinical presentation, again, very briefly referring to upper respiratory type symptoms, cough, sore throat, and breathlessness. Abdominal symptoms were increasingly recognized earlier on. They're, in our experience, not as common now, but certainly the earlier cohort of patients that we saw maybe about 8 or 10 weeks ago in our rapid assessment unit or respiratory assessment unit, there was a lot of patients presenting with abdominal symptoms, diarrhea, and so on and so forth. And obviously the loss of taste and the anosmia and stuff has been included in the list of recognizable symptoms now by the Department of Health as well. In floridly viremic patients, patients can present with shock, and which is no different from what you would otherwise see in cardiogenic or septic shock. Saeed has touched in much more detail on all the other inflammatory markers that we should be looking at, like leukocytosis. Now, that's not universal. We've had people with either minimal elevation in white cell count or even normal white cell count, but with lymphopenia, which seems to be a very recognizable and reliable marker, elevated CRP downstream from interleukin-6, abnormal chest X-ray. Abnormal chest X-ray is present in our experience somewhere around 60 to 70% of the time, with features that mainly suggest diffuse bilateral patchy infiltrates. It tends to be less like consolidation. It tends to be fairly diffuse, ill-defined patchy infiltration, and it tends to be bilateral. And that's present in about 60% of the cases. In the world audit literature, I'm seeing somewhere around 50 to 55% prevalence. Hypoxia is clearly a bad sign and a marker for poor outcomes in the longer term, and therefore, and the need for high flow oxygen requirement is an indicator of a poor prognosis as well. Now, Saeed mentioned earlier on, and I think because it's my particular area of interest, I'll talk about troponin. The evidence around troponin is that roughly around 25% of patients will have a troponin release. We have in the last several years learned to recognize troponin as a fairly reliable marker of myocardial injury in the context of acute coronary syndromes. And depending on where you work and what system you have, at the front door of the hospital, whether that is a cardiology admission unit or whether it is the emergency department, there is this prevalent clinical behavior which says, if the troponin is elevated, call the cardiologist because this is an acute coronary syndrome. Now, I think we need to perhaps rewind on that a little bit and change our mindset. The presence of troponin elevation in this context, in the COVID context, is really no different from CRP or lymphopenia and so on and so forth. And it should be dealt with in that context, but as an additional marker for poorer outcome. And there are data now suggesting that if you have an elevated troponin at presentation and you do serial measurements to show increasing troponin, then that is a reliable marker for the individual requiring intensive care management or a poor outcome in general. The BNP, exactly the same. They behave like acute phase reactants in any inflammatory process, as does the XDP D-dimer sort of axis, which is reflecting generalized out of control neurohormonal activation and inflammatory processes, which essentially is the biochemical way of shouting and saying, we are in trouble, do something, do some assessment and intervene to stop this process. Exactly what we do, we are learning. As Saeed referred to, and we've also practiced this, that we are now treating the end results of these tests, i.e. if the D-dimer is up and depending on how high it is, we change the weight adjusted dose of low molecular weight heparin administration and consider formal anticoagulation and so on and so forth. In the early stages of the disease or the pandemic presentation to hospitals, a lot of these patients landed up having lots of CTs, lots of contrast and so on and so forth. The experience tells us that you would still, because the coagulopathy is present in the background, and you would still be anticoagulating them even if they didn't show clear evidence of clot in the lungs. You don't necessarily have to rush in to do a lot of contrast delivery and a lot of radiation exposure if your clinical acumen tells you that you need to anticoagulate somebody. Now, if they don't respond and they're hemodynamically compromised, then to confirm the size of the PE, it would make sense to go for a CT scan at that stage. But for smaller and less hemodynamically compromising situations, we would anticoagulate, but not necessarily chase a CT scan as such. The cardiovascular presentations are phenomenal in the sense that they are very much like what you would normally see in any acute cardiac presentation. They come, arrhythmias are common, most commonly atrial fibrillation. There are cardiac arrests. We are seeing out of hospital cardiac arrest. We are seeing sudden cardiac death. We are also seeing ECG changes that are consistent with our typical presentations of acute coronary syndrome. We are seeing ST elevation. We are seeing ST segment, dynamic ST segments, depressions, T-wave inversions, et cetera. A lot of these patients who then either present with ST elevation infarction or are presenting with out of hospital cardiac arrest are being taken to the cath lab, where we are also finding that there is a slightly higher prevalence of infarction in the context of normal coronary arteries, as well as type 2 myocardial infarction, rather than a proper true acute occlusive ischemic coronary event. And the treatments for these are based on what the anatomy is. There's a significant number of these patients who do have the COVID, who then present to the primary cardiovascular presentation, go to the lab and have the box standard angioplasty and intervention carried out. We are seeing patients with heart failure, either acute or insidious, i.e. primary presentation with myocarditis up front with heart failure, or heart failure secondary to an acute coronary event that has happened, that has precipitated admission. There is obviously the linked sort of vascular problems of peripheral thromboses and stroke presentations. What is difficult to separate is these acute events happening in people who are already known to have vascular disease, either diagnosed or de novo presentation in people who had undiagnosed disease. And those are the difficult subgroups to identify, but the presentations, clinical presentation, the management is no different from what it has been always. The presumed mechanisms, I referred to this earlier on, there is a direct cell damage by viral infiltration or endocytosis, and that destroys the cell and then moves from cell to cell to cell, causing destruction in the organs, reflected by increased capillary permeability. You get the ARDS type presentation with lungs that are full of fluid. You can get that by peripheral vessels being destroyed and third spacing of fluid, and presenting classically with that, the combination that we heard of recently, which or just a few minutes ago, with a volume, intravascular volume depleted but fluid overloaded patient, which is extremely difficult to control. You then get the micro and macrovascular dysfunction, you have the immune system disruption, and then a later surge because the immune system circulates all the hormones that cause negative feedback on various cardiac function, leading to a multi-organ failure situation. And clearly, these are then multiplied by pre-existing disease. So if you've already got physiological compromised situation with poor physiological cardiac reserve, then any acute deterioration or an impact is going to make the clinical picture much worse and survival less likely. Age and overall vulnerability being two important sort of mechanisms. So looking at the third paper, which I looked at, is Liu and their colleagues, published in Circulation, American Heart Association recently, looked at the science underlying COVID-19 pandemic in the context of either pre-existing or de novo cardiovascular disease. And the suggestion was that if you had no pre-existing condition, so you're looking at the very last line on the slide, with no pre-existing condition, your actual mortality rate in that context is pretty much what you would get with a fairly severe flu infection. However, as you go up on the slide, the pre-existing cardiovascular disease then makes your mortality tremendously high probability, and in the order of about multiplication by a factor of 10. The pre-existing cancers, we know that people with malignancy, whether treated or not, have a poor or an altered immune mechanism, and therefore they are prone to concomitant illnesses and infections, and they do poorly. The chronic respiratory disease is not a surprise. Diabetes is not a surprise. Hypertension mortality rate. So this is what I was referring to earlier on. The suggestion in the earlier papers was that people with hypertension were dying more from COVID disease. But the argument was that the people who succumbed to the COVID-19 infection were actually in the age group where hypertension is prevalent. So whether the link with hypertension is just a function of prevalent disease in a vulnerable population, or whether hypertension is a causative or a cause and effect relationship, remains to be identified. But it is now noted to be one of the pre-existing conditions that makes your survival less likely if it is there and people get the infection. From the outcomes perspective, we have heart failure, myocardial pericarditis, vasculitis, infarction, as I explained, full spectrum of it, arrhythmias and thrombotic events. Roughly about 25% have elevated troponin, and that does reflect myocardial injury. The question is whether the myocardial injury is a primary ischemic event or is a secondary event due to the fulminant infection and so on and so forth, and type 1 or type 2 differentiation. But it seems to be a reliable marker for a poorer outcome in the longer term. There is some suggestion from a paper that I read about 2 days ago. There is a suggestion that serial elevation of troponin is a reliable indicator for the need for ICCU transfer as well, because it is telling you the myocardium is not coping. BNP has a similar profile to troponin, and these combinations of features that are commonly and easily measured in any medical ward should raise concerns around the expected outcome for that individual, and should be ringing alarm bells to put supportive and symptomatic treatments in place as quickly as possible. So with that background, I'm just going to very quickly talk about the heart failure in COVID patients. It is no different from the box standard heart failure. This is the standard definition of heart failure, which suggests that the cardiac structure and organ as such is unable to maintain an output which is in keeping with the demands of the body, irrespective of whether the cause of this inability is primarily cardiac or not, which basically means that the organ can be damaged itself and therefore not function, or it can be overwhelmed by a systemic illness, which then reduces its capacity to work. And the acute circulatory failure versus insidious symptom development perhaps seem to be two different mechanisms or clinical pathways by which it presents. Now, these are the very well-known causes of heart failure, i.e. you have less fluid or the pump is failing. And the various causes of either fluid loss or pump failure, and in the context of COVID, these are obviously the recognized mechanisms by which you might find both the pathways active. Severe septicemia, severe viremia, vasodilatation essentially gets you a relative low fluid status, and then the fever, the vomiting, diarrhea, the sort of stuff makes you lose fluid, so you get hypovolemic, and then clearly the impact on myocardium leads to pump failure, whether it is in the context of damage to the heart muscle itself or in the context of altered function because of persistent, resistant, or new arrhythmia. As we all know, 25% of the cardiac output is from atrial contribution to ventricular filling. So a new atrial fibrillation in somebody who's septic with vasodilatation, hypovolemia, you can imagine the impact that will have on cardiac output and what it does to the symptom status and the clinical parameters that we measure. The mechanism, again, is no different from what we already know about. The fall in cardiac output, whether it is volume loss or pump failure, activates the neurohormonal systems. And we've gone through what the renin-angiotensin system does to that. And then obviously there is a central sympathomimetic impact, which causes increase in heart rate and vasoconstriction that contributes to try and preserve as much perfusion to vital organs as we possibly can. And that leads to the symptoms and the signs that we perceive on clinical assessment. The suggestion is that somewhere around 1/5 of the patients presenting with COVID will sustain a myocardial injury of some description, whether it is direct infiltration of the virus into the myocardium or whether it is a neurohormonal immune-mediated impact on the myocardial function I think is academic. There is some data from the European endomyocardial biopsy stuff, which is suggesting that the virus material is present in up to about 80% of patients who are, so these are obviously autopsy studies. There are very few centers who will be brave enough to take on doing endomyocardial biopsy in live patients in the current climate. So these are post-mortem studies that I'm referring to. And therefore, by that token, perhaps more selective as well, and then selection bias will impact on this, because these are people who've died of myocardial injury, and therefore you expect that there'll be a greater prevalence. So whether this translates into how this translates into general population of COVID positive, asymptomatic, COVID positive, non-cardiac patients, I don't know at this point. But what we are sure of is that whatever the mechanism of myocardial injury is, as soon as the clinical manifestation of myocardial injury comes in, there is clear sort of indication that the outcome is going to be poor, and roughly about half of these patients, half of the patients who died due to a cardiorespiratory collapse disorder. So management depends basically, on how we treat symptoms and how we can support patients and hope that we can alter the course of this illness. The very few RCT data, I think I'm privileged to have access to some of the viral stuff that is coming out of Oxford and Cambridge. And day before yesterday, remdesivir is the study they were looking at hasn't been reported and is in publication suggesting that remdesivir shortens the duration of illness from 15 days to 11 days in symptomatic patients. Does that mean that they have less mortality? I'm not sure. The numbers are relatively small and the data is still being looked at. So the headline data is that the duration of illness is shortened. People feel better earlier using remdesivir. We are still waiting for the details on other data being collected as part of that. There's, as Said said, and we all know, large number of RCTs are ongoing with antivirals, antimalarials, immunomodulating agents, including steroids. Bit of caution around the antimalarials. There is obviously anecdotal data suggesting that these are helpful, but we as cardiologists should be very clear when we talk to patients, and I believe you me, there are patients who ask these questions on a regular basis, is that the risk of having things like torsade de pointes, ventricular fibrillation, other malignant arrhythmias in the context of patients having antimalarials, but without knowing what their predisposition towards these malignant arrhythmias is. We just need to be very cautious in how we accept and allow use of these medications. There is some suggestion that ACE inhibitors and ARBs may be protective. Whether this is to do with the behavior of ACE2, which changes when ARBs are present, i.e. the ACE2 as a feedback mechanism gets down-regulated, or it's still present in high numbers on the cell surface, but its behavior changes because the ARBs are also modulating it. That is speculative, but there is some signal to suggest that the use of ARB ACE inhibitors might in fact be protective. So the treatment basically depends on, is divided into three groups: symptomatic, supportive, and prognostic. The symptomatic treatments are pretty straightforward. You deal with the oxygen requirements, whichever way you want to, NIV or non-invasive ventilation. We've been historically in the context of cardiovascular presentation management been used to using morphine and diamorphine to for people with acute pulmonary edema and breathlessness and hypoxia and type 1 respiratory failure. We just need to be conscious that the mechanism of hypoxia in COVID patients is different from pure acute pulmonary edema. So just be aware of that. The symptomatic treatment with pain relief, paracetamol, et cetera, diuretics. Changes may be ARDS. We just need to be clear. We do not want to have people dehydrated over and above their third spacing, which gives us that problem about intravascular dehydration and extravascular fluid load. So just be aware of that. People have used nitrates. I've used nitrates in the context of COVID, but I've always made sure that we get an echo done before, so I understand what the filling pressures are. And just to add on a little bit to what Said said earlier on, is that there is another very easy mechanism of understanding what the fluid status is by looking at the right ventricle filling on an echocardiogram, and the patterns will tell you, and we can measure indirect measurement of wedge pressures and so on and so forth. So just be aware that that can be done. For those of us who have an interest in echo as well, there are pretty reliable data on good echo being able to provide very, very good measurement of hemodynamics within the cardiopulmonary physiology, rather than having to depend on invasive procedures. And beta blockers, I mentioned beta blocker as a supportive treatment for heart rate control, for atrial fibrillation ventricular rate control, and for control of, say, ischemia or angina or heart failure. And there is pretty good evidence for the use of beta blockers in acute heart failure now as well. So just be aware that that is an option available, obviously with monitored surroundings. We need to, well, I don't want to be in direct conflict with Saeed, but I do wish to say that if there is somebody who is in florid pulmonary edema and your echo is telling you that the ventricle is knackered because left ventricle is dilated and so on and so forth, and therefore I suggest that the threshold for echo should be very low, then avoid fluids, IV fluids in that context if you can. Prone positioning with or without ventilation, Saeed has talked about it. We are obviously seeing in some patients this being used and used to good benefit. Chest physiotherapy is something that one can undertake. Obviously, the monitoring of all the physiological parameters that allows you to measure what the response to your intervention is. Measuring things like BNPs, troponin, CRP on a serial basis, and early echo and repeat echo later on, because as I mentioned earlier on, there is that initial impact and there might be a delayed neurohormonal impact with the cytokine surge, which basically can be picked up with echocardiography. If the cardiac function coming in was good and going, and when the patient deteriorates, the LV dysfunction is poor, then it tells you what the prognosis is going to be. If the cardiomyopathy is confirmed, Saeed has spoken about the renal replacement therapy. ECMO is an option. I'm not a great fan of inotropes and sympathetic stimulants, although in the short term, most ICCUs will use adrenaline, noradrenaline on a very, very frequent basis to support. I would urge a little bit of caution with these drugs, because clearly if you've got somebody, and this is the experience on our normal clinical presentations of heart failure as well, is that if you've already got a struggling heart, then driving the heart rate or the force of contraction can sometimes have a detrimental effect. So just be cautious using things like inotropes and synthetic stimulants. I question the role of left ventricular assist devices. We're not into the life cycle of this illness long enough for us to understand whether A, LVAD is feasible, and two, whether it is going to be beneficial. But I'm absolutely sure that there will be people looking at things like balloon pumps of different types in ICCU settings to see if they can help with the cardiac flow and cardiac output to have an impact on the outcomes. I've mentioned the remdesivir, and these are basically the prognostic interventions. There is invasive ventilatory support, but we know that while we are assessing people upfront, measuring their parameters, and then referring to ICCU where they're being supported, the very fact that they are going to ICCU and require respiratory support in itself is a negative prognostic indicator, and the survival seems to be poor. Proning seems to have a positive impact on some subgroups, but not all. I've mentioned ARBs and the role there. Managing arrhythmias, acute coronary syndrome, heart failure, as you would in normal circumstances, is very, very important, because you don't want to be missing out on managing a reversible cause, which just happens to happen to somebody who is affected by COVID-19. And I think we need to be cautious around how we prognosticate when patients are coming into hospital with COVID-19. Just because somebody has COVID-19 and might have comorbidities doesn't mean that the treatments should be either limited, restricted, or withdrawn without a proper thought being given to what would make a difference to their outcome, or what would change the overall picture to allow patients to recover. And my concern is that because we are seeing floridly viremic patients coming in with hemodynamic compromise, that we, based on a short time of collection of data of 5 or 6 months in the pandemic, we're making decisions upfront around do not resuscitate and so on and so forth. I don't think they're necessarily wrong decisions or incorrect decisions, and I think it is important we do assess the need for these, but I would urge a word of caution to say, make sure you've looked at all the reversible sort of options before saying we can't do much for any individual. Of course, there are patients who are, young 35, 40-year-olds who have no comorbidities and who are very, very poorly, and we don't talk about do not resuscitate there. Then there are other people who are in their mid to late 90s and they're coming in with high comorbidity, and we know that the gain in terms of life prolongation and stuff like that is extremely limited. So there are those two extremes that you can perhaps very sensibly say, yeah, I am or I'm not going to talk about resuscitation here. But there is a big, broad group in the middle where careful consideration needs to be given to what is the right decision. The aggressive monitoring and management of coagulopathy is critical. You can treat coronary artery disease, you can treat heart failure, you can treat respiratory problems and get them out to the ward, and then their coagulopathy kills them because they've had either a massive stroke or a massive pulmonary embolism. So just be aware and upfront with monitoring and treating the coagulopathy, and that's critical to survival, in my opinion. So in conclusion, what I would say is it's a highly infectious person-to-person transmission. Most patients have a mild or asymptomatic clinical course. 16%, roughly 16-70% have a severe illness with a significantly variable reported mortality rates ranging from 1.6 to about 12%. I think these are unreliable. I think we are unreliable because no one in the world has taken at the moment, no one in the world at the moment has published fully reliable data on what the background prevalence of COVID-19 is in the population, including the incidental positives, asymptomatic positives, symptomatic positives, survivors, and dead positive patients. And therefore, we have no understanding what the denominator is. What we're looking at is snapshots of people who are coming into hospital, and most people come into hospital because they're symptomatic. So you're looking at a percentage of the overall COVID positive patients in the world. So just be careful how the prevalence data and mortality data is interpreted in that context. We had, if you remember, when the pandemic was announced by WHO, the suggestion was that the mortality rates were going to be similar to flu, i.e. less than 1 to 1.5% overall. And that was based on some modeling work that suggested that if there was a prevalence, a certain level of prevalence in the population, it would do two things. One, it would perhaps induce an immunity, which is the so-called herd immunity type sort of concept. and like the flu viruses do. And also it would allow you to have a larger population of positive patients, but a very small percentage of people with bad outcomes, i.e. an acceptable level of mortality, et cetera, et cetera. So just be aware of how this data is interpreted, because we don't know what that denominator is. There are, however, very easily identified pre-existing clinical diagnoses, and most of these are cardiorespiratory. I'm deliberately not talking about the people with, say, hematology cancers, or already established on dialysis and so on and so forth, because they are extremely high risk group and vulnerable group, because their immune systems are already modulated and modified. But in the cardiorespiratory context, things like long-standing respiratory illnesses, coronary artery disease, arrhythmias, heart failure, and so on and so forth, are easily recognizable clinical diagnoses that tell you that people with these conditions, if they get COVID-19, will do poorly in the longer term, and we need to identify them upfront and protect them as much as possible. And I'm coming to the last slide. So symptomatic and supportive treatment should be instituted early. Close monitoring of biochemical, hemodynamic, and respiratory parameters is absolutely critical. Need for invasive ventilation seems to be a strong indicator of a poor outcome. So my practice has changed in the sense that when in the normal circumstances, in COVID negative heart failure or acute myocardial infarction or cardiac arrest patients, I am keen to get them the ventilation support, because I know that all they need is a period of rest, physiological rest from normal working, and then they will make a recovery. If I do this early, there's a better chance for them to improve. In COVID type circumstances, I know that if we're getting to the stage of invasive ventilation, there is something that patient's physiology is telling us that it doesn't like and is unlikely to do well in the longer term. For these vulnerable patients in whom we know that there is pre-existing condition and so on and so forth, shielding or isolation is probably sensible to consider. And obviously we wait for the RCT outcomes in the longer term and hope that we will be able to get some reliable prognostic indicators that we can modify, and we will have treatment that will impact on the outcome, hopefully in the longer term. So watch this space. Thank you very much. That's me done. I hope it's been helpful. I'm open to questions if people wish to ask any. I'm going to exit this.
Thank you very much, Professor Junejo. That was a fantastic talk. At this stage, I'm going to ask Dr. Hind Al-Zain to get her presentation ready, because what we'll do is we'll go straight to the case presentations, because there will be plenty of opportunity during the presentations to stop and ask questions and discuss points. So, Dr. Hind, will you be able to get your presentation? Prof, if you can unshare your screen.
I'm just looking to do that.